Hello, everyone. This is Gastrointestinal Endoscopy Auto Interview. I'm Norio Fukami at Mayo Clinic, Arizona, and I have my co-author, Dr. Mohapatra. Dr. Mohapatra?
Thank you so much, Dr. Fukami. So, I'm Dr. Sonmoon Mohapatra. I'm the gastroenterologist and advanced endoscopist at Sai Institute of Gastroenterology and Liver Sciences in India. So, I completed my advanced endoscopy fellowship training from Mayo Clinic, Arizona with Dr. Fukami. On behalf of my co-authors, I'd like to thank GI Endoscopy for the opportunity to present our study, Outcomes of Submucosal Tunneling, Endoscopic Resection for Subepithelial Tumors in the Upper GI Tract, experienced from the United States.
Wonderful. What sparked your interest in evaluating STIR procedures and outcomes for upper GI subepithelial lesions in the Western population?
Yes, we were increasingly performing STIR procedure for the upper GI subepithelial lesions in our centers, yet most of the published experience and the outcome data come from the East Asia, where results have been excellent. So recognizing that the patient profiles, referral patterns, histology, and even the training pathways that differ between the regions, so we felt that it was important to assess how STIR performs in Western practice. So our goal was to validate its feasibility and safety, particularly for the lesions suspected to be GIST or originating from the muscularis propria layer in the West.
Great. Can you briefly walk us through the study design used in this study?
So this was a multi-center retrospective study conducted across 8 U.S. tertiary care centers. We included upper GI subepithelial lesions that were symptomatic or originated from or were inseparable from the muscularis propria layer on the EUS and had inconclusive or non-diagnostic EUS fine needle aspiration or biopsy, but were still suspected to be GIST. So, Dr. Fukami, why do you think that the muscularis propria origin or suspicion of GIST consider an important threshold for STIR?
That's a good question. If the lesion is originating or attached to muscus propria, the traditional resection such as EMR or ESD would result in full thickness perforation. It becomes EFDR. On the other hand, surgical resection is effective that it has more morbidity and longer recovery time. STIR offers an opportunity to enucleate the stromal tumor by creating submucosal tunnel. It's a really good protection against the leak, and it's a safety if even though you do transmural resection going through the wall. And suspected GIST are really irrelevant because any diagnosis of GIST would advocate resection if feasible or treatment with other modalities. So for the GIST and other lesions such as the stromal tumor coming from muscus propria, STIR would offer really excellent opportunity to do minimally invasive organ-sparing treatment. Now, question to you, briefly summarize the patient and lesion profile and what were the most important findings from the study?
So we evaluated 47 patients with 51 subepithelial lesions with a median size of 25 millimeter, and majority of the lesions, they were located in the stomach, that is 58.8%. 39.2% were in the esophagus and 1.9% was in the duodenal bulb. So notably 82% had undergone prior sampling and 19.6% that demonstrated submucosal fibrosis exclusively in previously biopsied lesions. So the median procedural time was approximately 90 minutes. So the key outcomes in our study included the unblocked resection as well as the retrieval rate, that was 94.1%. The adverse event was 14.8%, with the mucosal injury 8.5%, and all of them were managed endoscopically. The transmural resection, that was defined as STIR involving intentional perforation through the muscularis propria layer or the serosa, that was 21.6%. There was no recurrence observed at a median follow-up of 17 months. So collectively, this result supports that the STIR as a highly effective and durable treatment options when performed in experienced centers.
Those are good findings. And one thing that I want to add is that biopsy included the endoscopic biopsy and USFNA or FNB. And endoscopic biopsy did not show any etiology, correct?
That's correct. That's correct.
Great.
So my next question to you is, so based on our study finding, would you advocate limiting pre-resection sampling to avoid fibrosis, so to reduce the rate of transmural resection? And if so, where exactly do you draw the line between the diagnostic confidence and the procedural risks?
The biopsy would give you the confidence of diagnosis, pathological diagnosis. On the other hand, biopsy would increase fibrosis and difficulty of the procedure. So it prolonged procedure time, and you may require to do transmural resection. That's what we found. If the tumor is already indicated for resection, symptomatic tumor or highly likely to be GIST, I think we can advocate no biopsy and proceed with the resection. However, if the patient has a high comorbidities or multiple comorbidities, risky to proceed with the resection, it is important to have a pathological diagnosis to make sure this is a proper indication and to exclude other etiologies. My question to you, our study examined the case of transmural resection, right? Predictor for transmural resection were extraluminal extension, GIST pathology, and fibrosis. How might this guide case selection and procedure counseling of the patient?
So these predictors would really help us to anticipate the complexity of the case and the prolonged procedural time. In that way, inform the patient that the procedure may involve a full thickness resection and longer duration, so that we can be prepared with appropriate tools like clips, suturing devices, and over-the-scope devices, etc., and appropriate backup and exit strategy. So in counseling, we can explain that certain features such as the presence of extraluminal extension, suspected GIST would raise the odds of transmural resection, but this does not necessarily translate into a higher risk of adverse events when performed at experienced centers.
That's important.
Yes. So the next question is, how do you interpret the finding that no recurrences were observed over a median follow-up of 17 months?
Yeah, so 17 months is long, but it's not long enough for these slow-growing tumors. There's still uncertainty how to deal with the one resection, high-risk tumors on the pathology, and we probably need longer-term follow-up to make conclusion. Now, final question: what is the biggest takeaway from this study?
Yes, so our study showed that STIR offers a highly effective and minimally invasive organ preserving alternative therapy to surgery for subepithelial tumors. Those are inseparable from muscularis propria layer with acceptable rate of adverse events, which was now validated in the US population. So minimizing pre-resection sampling may reduce fibrosis and improve technical feasibility of STIR.
Great. Thank you very much, Dr. Mohapatra, and thank you very much, gastrointestinal endoscopy staff and editors. Bye.
Bye-bye.